My name is Neil Wetzig. I'm the Vice President of the G4 Alliance Permanent Council. And on behalf of the G4 Alliance Executive and Basola, who's the President, who's unable to be here, it's my pleasure to welcome you to this important evening discussing bringing surgery and anaesthesia into primary healthcare. And I just want to acknowledge the partners for this event, the International Federation of Surgical Colleges, Operation Smile, Smile Train, and the World Federation of Societies of Anaesthesiologists, WFSA, as well as the Southern African Development Community Technical Experts Working Group on Surgical Healthcare. I am part of that group, but I still have trouble getting my tongue around it, Emmanuel, but anyway. It's a pleasure to have you all give up your Monday evening to be here. And as you can tell by my accent, I'm an Australian, but I work in the Democratic Republic of Congo, hence my fancy tie. I'd like to welcome now, where he is, Van Australia, who's the current president of the International Federation of Surgical Colleges. Fanis is going to be our moderator for the evening, and he will, he also has a very colourful tie, but he will introduce the guests that we have speaking tonight. Thanks, Fanis. Oh, I think I was supposed to say something about the G4. There you go. Forgot that one. So in case you're on, I think most of the people here are probably aware of the G4 Alliance, but it's the Global Alliance for Surgical, Obstetric, Trauma and Anaesthesia Care. We would like to think it's the leading advocacy group for universal access to quality, safe, timely and affordable care for surgical patients. And we have 80 members that represent civil society, professional organisations, universities, academic centres, colleges of surgeons and other colleges and non-profit organisations. I represent Heal Africa, a non-profit NGO in Congo. So just to give you a little bit of background, our quick mission statement for the G4 Alliance is to advocate for the neglected surgical patient. On that note, I will now hand over to Fanis.
Thank you. Thank you, Neil. I would like to invite our panelists to take seats here at the front, please. And then I'll introduce them once they're here. I just wanted, while they're coming up, I want to start with a disclaimer. When I say surgical care or surgery, I mean the whole gamut. From pre-hospital care, emergency care, operative, what we call it, surgical, palliative, rehabilitation. As a surgeon, I've done all those things. So that is what, if I say surgical, please, it includes nursing care and perioperative care. It includes the people who serve our anesthetic machines, or who make sure that the small first-level hospital has water running. So it's for all those people that we're speaking tonight. So if I say surgical, please don't pull me up every time. I cannot explain the whole lot. I don't have a big enough memory bank for that. So please, can I ask you to come up? I will, or if you're reluctant, then let me introduce as we go along. But I'll wait for you all to come and sit, please. So we have, I'm going to start in the corner. We're honored to have Ambassador, His Excellency Ambassador TEWG Daka. He's the ambassador of the permanent mission of Ethiopia to the UN office in Geneva. Thank you very much for joining us, sir. We appreciate that. We just want to assure you that there will be no diplomatic immunity tonight from difficult questions from the moderator. Then we have next to him Mr. Tore Lærdal. I say Lardal, but Lærdal. I'm sure you all know the company, Lærdal Masks, Risas Ann, and a few others, New Natalia. But, you know, there are very few people who doesn't have a profile on Wikipedia if they are that important in the world. I don't know, I think you must have paid them a lot of money to not have a profile. If you look up Lærdal on Wikipedia, you only get the foundation and Lærdal Global Health. Even on the website, it just says his picture, Tore Lærdal, founder, funder. I asked him for a bio so I could introduce him. He sent me 3 lines just about the foundation and global health. We have Terry Reynolds next. I'm sure you all know Terry. Terry is lead in clinical service and systems unit, the Department of Integrated Health Services at WHO. Terry, I know you don't like that picture, and I apologize, I didn't put it up. So, Terry said a very nice thing to me a year ago. I was the only surgeon in about 40 advisors to help get the learning strategy for the new WHO Academy written. She said, you must have done something right because 3 of the first 10 proposed courses are surgical. I don't know if that materialized, but I felt so good about that. I'm not going to check that ever. And then we have Emmanuel Makasa. I'm sure you all know he's professor and director of the WITS SADC Regional Collaborative Center for Surgical Healthcare or Healthcare Improvement. WITS, he's also consultant trauma and orthopedic surgeon at University Teaching Hospital in Lusaka. I first met Emmanuel in 2009 when I was giving a lecture on research and audit in surgery in Lusaka. He was the only one of the trainees wearing a 3-piece suit, and he was the only one who interrupted me regularly with really impossible questions to answer. Now, since then, we've had a few good bottles of wine together. I see he's ditched the 3-piece suit, but the questions still keep coming. I've Naima Yusuf Zakaria. She's consultant anesthetist and director at Tanga Regional Referral Hospital in Tanzania. For those of you who are geographically challenged, Tanga is about just over halfway between Dar and Mombasa on the coast, opposite Pemba, which is just north of Zanzibar for you holidaymakers. So anyway, we met in 2014 when I was teaching at a course, a critical care course, and the last module was on end-of-life care, and that's an open discussion, and I'm a bit flippant sometimes about death and dying. I'll admit that, but Naima and a friend were there, were the only 2 wearing the hijab. And I said to myself, Dreyer, you're in trouble today. You're going to say something that's either culturally or religiously totally unacceptable. And then they blew me away. They were so open in discussion. It was one of the best discussions we've ever had, much more than the boys. So we have Desmond Jumbam next, also known as Tanko. He's Director of Health Policy and Advocacy for Operation Smile. He's Cameroonian. We share some quote from Samuel Eto'o, but he's based in Ghana. Desmond came to notoriety or in 2020 when he wrote the seminal editorial how not to write about global health. If you haven't read it, look it up. I think you can use that piece as an example of sarcasm in a journalism course. So that's after that we got in touch. And then next to me here, I have Dr. Wisława Pawlikowski-Amiel, Director General in the General Office of Technical Cooperation, the Ministry of Health in the Government of Peru. She previously was the lead for Operation Smile in that area. I don't know her official title, but when I met her 18 months ago, she was the most unusual of plastic surgeons ever. She was not working in private practice, but she was doing reconstructive surgery for kiddies in a government hospital in Peru, in Lima. So that's the panel. You must agree with me. It's a fantastic panel. Now, how do we pull all these people together? There were excellent people who did this and I must commend the young people in the organizing committee, Natalie, Sarah, Chris, and Francis, who really got this going. But then we were struggling, how do we make this work? And then we had this fantastic opinion from the president of G4 who attended one meeting, Bisola Onajin Ubembe. And Bisola said, remember, we're building a house. What's the most important in the house? Is it the foundation? Is it the walls or the floor, the water supply or the electricity, or the roof, the kitchen, the bathroom, the lounge, the bedroom? And sometimes we disagree. I don't like the colors my wife tells the painter to use, but it doesn't mean I break down the house. So we're all building this house. And if you really look at all the resolutions, if we look at the groundwork for surgery in primary healthcare, in my opinion, was done in 1978 with the Declaration of Alma-Ata. There's a lot of surgery in there. And 6815 had primary healthcare. 7216 about emergency care, and in UHC had primary healthcare. ECHO is based on primary healthcare. We have primary healthcare as the core of where WHO wants to go. So that is why we chose this topic. But just one last word before I get to the questions. I'll stop speaking. And that is that what makes a house a home are the people. The people we're talking about in this house are our patients. Let us never forget that patients are wounded storytellers, to quote Arthur Frank, for those who've read the book. Our patients get traumatized physiologically, physically, socially, psychologically, and financially. With all our best intentions, many of them never recover from one of those aspects. And this is what this is about. How do we get universal access to everybody, especially those who have no voice? And that's what we're here for tonight. And that's what the questions will be about in the end. So talking of patients, I thought the best would be to start with patient stories. And we could have selected lots, but we decided where else than start in our own panel. So I'm going to ask Tore first to tell us his patient story and how that led to you all knowing about Risa's Annie.
Hello, everyone, and thank you very much for the honor of being invited to this prestigious panel. I am the odd man out, not being a clinician. but I represent the lay public and really the primary health, if you like. And my story, which I was invited to share, goes back to the 1950s. And that was in the early infancy of anesthesiology. And it was at the time when the patient was considered to be dead when he or she stopped breathing or the heart stopped beating. So much has changed since that time. And we know today that an estimated 30 million deaths are considered to be time-critical emergencies. And that is representing a situation where, in most cases, the brain is deprived of oxygen, and death is, as was redefined around 1960, is no longer considered to be a moment, but a process, a dying process that can be reversed with an efficient chain of survival. And that sort of relates a little to my story. I was subject to a near drowning and just saved by my father at the very last minute. I was found floating and probably have been in the water for a few minutes with the head down. I was only kept floating by an air pocket that was trapped in my raincoat. And my father got hold of me and instinctively shook me, held me upside down, and was able to make me vomit. And after some long seconds, I'm told, I was only 2 years at the time, so I don't remember much, but I started to cry and breathe. My father was a doll maker at that time and had actually just introduced what became an international success within the toy industry. It was the first doll to have stitched hair, sleeping eyes, and soft unbreakable parts. It was called the Anna doll. But when he heard, and actually from his father-in-law, who happened to be a well-known surgeon, about the new resuscitation methods that were established around 1960, he got almost obsessed by the thought of now making a life-size, a lifelike doll that could help train the masses, because he was convinced from his own experience that really this needed to start with training the school children and the lay public. And with the help of a anesthesiologist in Stavanger, Bjørn Lind, Resuscian was developed, and the rest is perhaps history, but the American Heart Association has estimated that perhaps some 500 million people have been trained to be lifesavers using this technique and the training doll since that time. So that's my story.
Thank you very much, Tore. I'm going to ask Desmond next to share us his story and the impact that happened to him while needing surgical and anesthesia and supportive care around that during the pandemic. Desmond, thanks very much for being prepared to talk about this.
Thank you, Fanis, and hello, everyone. My name is Desmond, as Fanis has said, and many of you know me as a global surgery researcher. Spent quite a bit of time with John Muir and the team at Harvard PGSSC. But about 2 years ago, I had the chance to experience, some little bit of what it feels like to be a surgical patient trying to get care in Cameroon. So in April 2021, I was with two friends traveling from Yaoundé, the capital of Cameroon, to Douala on one of the busiest highways that connects the port city of Douala to the rest of Central Africa Republic. Also, one of the deadliest highways in Cameroon, probably West Africa. And as we're traveling on that road, I'm working on my laptop on the front seat. And as I look up, I realize that, we've lost control of the car. I'm in the passenger seat. And, we're heading straight for a semi-truck that is coming in the opposite direction. The driver tried to brake, but, it was too late, crashed into the huge semi. After a few seconds, I woke up. And thankfully, my other two friends were fine. Nobody died. So we thank God for that. But then I was dragged out of the car because I realized that I had sustained a femur fracture. So, some bystanders took us out of the car, laid me down on the ground. And as I'm lying there, traumatized, I think to myself, thank God World Health Assembly Resolution 68.15 passed. No, I did not. I did not think that. And I say that not as a slight to resolutions, but to emphasize that, to the patients, resolutions are only important until they reach them. In that moment, I was not thinking about WHA Resolution 68.15. I was not thinking about the difference between surgical and operational. I was thinking about how I would get to the hospital and get the surgical care that I need. And so, the bystanders were able to get a private car that transported me to a nearby health center, where thankfully they had some pain management for me and some stabilization. Again, a private car took me to a hospital in Yaoundé, and at a private hospital there, I got my treatment. While at the hospital, again, I was very cautious. I knew a lot of, you guys in the room, surgeons, and so I kept calling my friends and saying, okay, is this the right nail? Is this the right medicines? Are they giving me the antibiotics? So I had access to all this knowledge and all these people. And I also knew the research. I was worried because, we know that Africans, and those in low and middle income countries, surgical patients tend to be younger and with less comorbidities, but they're 2 times more likely to develop a surgical side. I knew the research. I was hoping that I wouldn't be one of those, 2 people. But unfortunately for me, 2 months after this surgery, after 2 months of rehab, I realized that I developed a bone infection and an osteomyelitis in Ghana. So the surgical procedure had to be redone, had to have antibiotics treatments for weeks. By the way, the antibiotics that I got, one of them had to be flown in from South Africa because it wasn't available in Ghana at the time. 6 weeks or so of antibiotics, rehab again, and thankfully the operation was successful in Ghana. But then again, I realized there was another complication from the surgery. So I had to go to the US and got my care done there. The whole process was extremely costly, very stressful. The antibiotics and everything. I just happened to be, I think what blew me away was the fact that I think I consider myself a relatively privileged person. Just being in this room, being on this panel, I'm very privileged. And this is the quality of care that I got in my own country. So it just showed me the urgency, like what is the reality for those in rural areas? And then the second point is, again, to my comment, is resolutions are important. We've come a really long way, but we have to be careful to congratulate ourselves until we get to that patient lying on the ground in the OR in the community. So that's my story. Thank you, everyone.
Thank you, Desmond. You might as well keep the mic because I'm going to ask you, what do you think, in general, could have been better if surgery and anesthesia was really part of primary health care? And while you're at it, please explain to me and the other surgeons in the room here who think like plumbers or mechanics or carpenters, because that's how I see myself. please explain to us what's the difference between primary care and primary health care in the process, if you don't mind.
Sure. I don't mind, I'm up here. Primary health care and primary care are very much related, although they're separate things. Primary care is a part of primary health care. It has more to do with diagnosis and treatment of the particular condition. And you have your primary health care physician, typically when you have a condition, and then if there's need for specialty care, then you get referred. I think primary care is part of primary health care. So there's that, plus there's health promotion and there's health prevention. And so in my case, if there was better primary health care in the Cameroonian healthcare system, there would have been a quicker response to my situation. I remember lying there on the ground, really traumatized, and people were looking at me. I said, well, what are you looking at? Call an ambulance, get somebody here. But the response was not there. Getting me to that health center, the health center needed to have the medication and the expertise to stabilize me before being referred, right? So that could have been better. The other thing is primary health care is not just surgical care, but there are many things. Mental care. My partner who was in the car with me, when we got to the hospital, received very little attention because she wasn't traumatized. She didn't have any physical trauma like me, but she was mentally traumatized, and that is not visible. And there was no attention paid to that. And so she struggled for a while with that. So I think primary healthcare would take into consideration all these other aspects from the site of the accident, the crash, all the way to completion, and even talking about the physical therapy that I got in the community, right? It's all encompassing. So.
Thanks very much. So we've spoken now about sort of individuals, but I want to ask Neema next. Neema, Tanga Referral Hospital is the referral center for over 35 hospitals. And for many of us, that's just unfathomable, I think. Now, tell us, during the pandemic, how was your ability to provide surgical and anesthesia care? I know you're an anesthetist, but you work a lot with obstetricians, but how was that affected? And what could have been better if we had surgery and anesthesia really embedded in primary health care, please?
Thank you very much for the question. Hi, everyone. I'm Neema from Tanzania, Tanga. And yes, during the pandemic, it was a challenging environment, I think all over the world, but especially on our side, because first of all, we were not supposed to say it's COVID due to the politics reasons, but we kept on receiving a lot of patients. And it was, the way it was advocated, it was like as if it's Ebola. So even the healthcare professionals were not very confident in giving care to the patients. And my hospital is the only regional referral hospital in Tanga, which serves more than 40 district hospitals. We have, like, Tanga is the biggest region in geographical area in Tanzania, which has around 11 districts. It's the first of all. And so we receive like a lot of referrals, and we are also bordered with Mombasa, where also the patients kept on coming from Kenya. So the burden was a lot, stigma from the healthcare providers, but also stigma from the patients themselves, the caretaker. So it was really challenging, and we had to like put a lot of resources, but also a lot of work into taking care of the patients who came in a very bad state during COVID time. And most of them were also, some of them had upper respiratory problem, not because of COVID, but because of the heart condition or anything else like TB and stuff like that. But it was so hard to differentiate during that time because everybody was in a really panic situation. And we are few in the hospital, like in a government hospital. We don't have we are supposed to be 600 working there, but we are only 250. So you can expect, you can feel the services which we had to give during that pandemic area. And we had to like kind of jeopardize the other services, especially the surgical services, because everything was very new, and with not having enough laboratory services to support the treatment we are giving was also very much challenging. But we somehow moved on, and the stigma was soon had to end, because you don't have PPE, you have to work with the gloves and the mask, and you can't demand much. So finally, the stigma took around like 3 to 4 months, and it was over. And integrating the surgical services in the district hospital or in the primary healthcare would have been a major, help to lessen the burden to the regional referral hospital. And this is exactly what we are doing now. Like there is every district hospital, which I mentioned, around 40, they have the working operating theater. Although there are some challenges because they're not theater managers, there are less anesthetic providers, surgeons, the whole team. But at least we have, and we can downstream the services, especially the emergency operations, not the big ones, but the like the C-sections and stuff like that. So that way we can then concentrate on big problems in the hospital. I mean, really the patients who are supposed to be referred. So it would have been a great impact during that time if the primary health care services would have had the surgical services embedded in them. Thank you.
Thank you very much. Next, I want to ask Terry. So if we talk about integrating, you've heard these examples in individual cases, but also in these in a massive area, and how commendable to start this at the 40 district hospitals. But Terry, in terms of policy and practical decision making, how can you explain to us, please, how do the integrated health services at WHO, how's that orientated into primary health care? And where is WHO going with this, as far as you know, please?
I appreciate that qualifier about as far as I know. It's kind of a large organization. Yeah, thanks for the question, Fanis. And I just want to thank, to start with, really Toy and Desmond and Naima for sharing their stories. And I know others on the panel have stories as well and have experienced these things very deeply. And the question to me is a bit more of a technical one, but it's, I don't see the technical concepts as an alternative to people's stories. I see them as a certain way of communicating people's stories and the solutions to get people what they need. So some of this sounds very dry, but I think it's actually quite powerful. So Desmond gave a fantastic answer about the difference between primary care and primary health care. And the aspects, the language, for example, that WHO uses about that is primary care is a delivery platform, a set of services, not the same everywhere, but usually, as he said, associated with kind of first contact care. So usually associated most often with the community and clinic level of delivery, and with a really strong emphasis on being close to home and on prevention and promotion. That's generally the constellation of qualities that people say when they think about primary care. Then primary health care is a very different thing. And let me say immediately, I acknowledge this is a very challenging distinction. I'm not sure that it's been propagated efficiently. They're used mistakenly, quote unquote, within WHO, outside of WHO at times. It's a different distinction to get a difficult distinction to get a handle on. And some of that's the terminology, but the concepts I think are clear to people. One is this group of services that Desmond described very well, and where they're located relative to people and their homes. Primary healthcare from a WHO point of view, and that's not the only point of view on it by any means, that's who I work for though, is a whole of society approach. And it has three key pillars. One of them is integrated health services. The other two are intersectoral action and policies. and then empowered communities and individuals. So when you work on a content area, say, or a continuum of care, like surgical services, like surgery and anesthesia, like eco services, you're activating usually all three of those pillars. You're activating the integrated health services, and Peru will be very aware of this because this is the terminology in which they work. Dr. Bislava is super familiar with this, uses it every day, right? The intersectoral action gets activated, the mechanisms for engaging individuals and communities. Vanessa asked me to focus on the integrated health services. I think that's important because, and this is kind of where this eco concept came from, was you can call these two things whatever you want, but it's a problem if you confuse them. So primary care is a limited set of services. It's arguably the most important part of the system. It's what we want at the center. However, primary care can't do its job without a surrounding support of these emergency, critical, and operative care services and others. So primary healthcare is bigger and includes integrated health services, and those integrated health services include all services. It includes the operating theater. And it's true, you want early recognition of surgical conditions in primary care, and having good primary care is absolutely essential to making sure surgical care can deliver what it can deliver. However, saying that the operating theater is part of primary care is probably not true. It's probably not. You really, trust me, primary means first contact. You really don't want people knocking on the door of the operating theater without something in between, right? It's a scarce resource. Surgeons and the operating theater are a scarce resource. This is now our functional definition of hospitals at WHO. Hospitals are a concentration of scarce resources. They're not a building. And so what you want with a PHC approach is you want primary care at the center, you want all the integrated health services available, and then you want that supported by key intersectoral and policy actions, which is where the governments come in, and you want your communities and individuals empowered. And that can sound very abstract, but what is meant by that is everything should be planned around communities' needs, including where hospitals are placed. And had that been the case in Desmond's situation, had the first level hospital had the services it needed, the equipment it needed, the health workers it needed, his story would have been very different. And then you want it to start with communities. And similarly, Torre's situation came out very luckily. And now many people have experienced the same outcome that he did through design, by empowering individuals and communities. So the concepts can be used very powerfully. They are also confused. And what matters about the reason you don't want to confuse them is you want to make sure that a primary healthcare approach does include surgery and anesthesia and is not only limited to the clinic and the community. It's a very key part of it. It should be at the center. But if you want to place primary care at the center, you can not only act on primary care. Primary care generally puts itself at the center. What disrupts the centrality of primary care is the way that hospitals behave and are planned. So in order to put primary care at the center, what you want is action on primary care for sure, but you want the hospitals designed in such a way that they put primary care at the center. So you need primary care every day, right now. It's your promotion, it's your prevention. It means we probably shouldn't be sitting as long as we've been sitting all day. It means you probably shouldn't be eating what you ate today. That's primary care every day, but every lifetime needs the emergency, critical, and operative care services. I hope that there are people in here who haven't needed these services in their lifetime. It's probably not true, even though some of you are quite young. So it's a very different thing. So it's important that we acknowledge and accept and recognize the distinction between primary care and these other services. And it's also important that we insist that for the system to work, for primary care to do its job, it needs a supportive ring of eco services and other services. I'll stop there. Does that answer your question?
Thanks, Terry. Yeah. You talk about a circle of services. For my brain, that becomes a bit much. I'm thinking of an octopus, tentacles going everywhere. But but I've been thinking about primary health care really as a horizontal system where we're all equal in what we contribute. with different contributions. And for me, there's surgical services are often designed around specific problems. Operation Smile, Smile Train, burns, fistula, obstetric fistula. So how do we integrate these into primary healthcare? And I want to ask Slava, you get the difficult question. How do we integrate surgery and anesthesia into primary healthcare? What is your opinion, and what have you achieved, especially as so many surgical services necessarily, it's not bad, but necessarily are more vertical systems. And of course, there are the surgeons who all want to be cockerel on their own dung heap. But let's not talk about that. So Wisława, please.
Thank you. Thank you for the introduction and the opportunity to be part in this wonderful panel with this wonderful person. And thank you everyone for your attention. I would like to begin by saying that primary healthcare is the essential healthcare, care that is made universally accessible to individual and family in the community. And it is a basic strategy for the entire population. Thus, primary healthcare is the cornerstone of national and regional strategies using to achieve equity and human development. Primary healthcare has been implemented in various ways worldwide, incorporating diverse perspectives to ensure its effectiveness across different countries. Primary healthcare has to provide accessibility, individuality, continuity, longitudinal and palliative care for the patient of the population, and surgery and anesthesia are important aspects in the continuity of healthcare. This is the most important. No? And you are right, in my country, surgery and anesthesia do not necessarily articulate with the primary healthcare. Our healthcare system was designed to address health problems through vertical strategies. And let's take the example of the cleft lip patients. We have a strategy that provides diagnostic services. The patient born, and we have consultation in genetic, pediatrics, plastic surgery, ENT, dental rehabilitation, psychological support for parents, and blood test. And then the patient needs to receive pre-op treatment. So the patient will leave this strategy to put the next strategy to the dental strategy. When the patient finish the pre-op is this strategy, have to leave because the patient needs a surgery treatment. Unfortunately, surgery is not part of any of these strategies. So the patient is left to find surgical services. And then after surgery, he or she will need to return to dental strategy or other strategies like speech therapies or mental health or family support, because this is a complex pathology. Thus, despite the fact that all the treatment that the patient receives, including surgery, are covered by our public health insurance, the patient is left jumping from the strategy to a strategy, and we lose the treatment continuity, making the primary healthcare not efficiently. When we saw this problem in the Minister of Health, we started working to change the way that we provide care from the vertical system to into your horizontal system. We have started to create integrated network where we can provide continuous care. In this network, the patient will receive medical and surgical treatment for their pathology from start to finish until discharge. So far, we have created 3 networks to provide care for ophthalmologists, oncologists, and maternal and child care. And we'll continue with this strategy to provide all the aspects of healthcare that our population deserves. Thank you.
Emmanuel, you said something very interesting on Friday that I picked up on, but what I want to say is, you led the way in many ways in trying to implement the resolution on making emergency and essential surgical and anesthesia care, surgical care and anesthesia part of primary health care in the SADC countries. We've often spoken about first level hospitals, and what I've given a talk to your group about what is essential training in essential surgery. So we know that a lot of countries in Southern Africa, but also elsewhere in Africa, Pakistan, Pacific Islands, starting in Latin America, Ecuador just published, have worked on their sort of surgical systems planning, or what they known as surgical national or regional plans, and there are different names for this in different parts. But but what you said the other day was that these can be entry points for planning national healthcare systems within the framework of primary healthcare. I added the last few words. But can you please tell us how can, because to me that was a new concept, to think how can surgical planning, function as entry points for planning national healthcare systems? Please, if you don't mind.
Thank you,
It's my turn.
Pleasure to be here, and thanks to the panelists.
That's all.
It's off.
Oh, it's on now.
I think I need to bring it closer. Okay. Yes. So the National Surgical Healthcare Policy, I like to call it a healthcare policy because, like I said, it can have many acronyms, and those acronyms have obviously caused problems for us because it creates rivalries between the different professionals. The nurses say we're not there, the anesthetists we say we're not there, and the goal is not for us to focus on any profession, but to focus on the service that we deliver to the patient. And so we like to call them National Surgical Healthcare Policy, and surgical, obviously, including all the disciplines. These policies are a vehicle through which governments actualize their political commitments that they have made, either at global level or at regional level, in our case, obviously being the SADC region, because we didn't only make political commitments up here, we also repeated and recommitted ourselves at regional level, and then we support each other to then, first of all, designing these policies is a new thing for the countries or the member states. These are horizontal systems. The countries are used to developing vertical systems that are kind of very specific, malaria program, TB program, and things like that. Even their partners, like you said, sometimes speak on specific diseases, and then they design programs on that. Now, when we develop these policies, obviously, the focus is to ensure that they can support the countries to achieve universal health coverage, which is good health and well-being for everyone. And so the district hospital becomes the center of that kind of investment. We know that obviously the district hospital is part of the health system. It doesn't survive on its own. It supports the higher levels, but it also supports the community and the clinics, from the community. For specialized services like surgical services, surgery, obstetric, anesthesia, perioperative nursing, we can't take them further than the district hospital. Like Terry said, they are quite specialized. The safest and best place to provide them and nearest to the community is the district hospital. So how do they then become an entry point to design or strengthen systems in primary healthcare? things that are arising from the community or in the clinics, or what if you look at the health system and put it in blocks, there's a primary health care, and then there's a district hospital, which is right at the apex of, and then the second level hospitals, and then you go higher. The district hospital then, like I say, it has two roles. First of all, it's right at the apex of the primary health care. So everything that's coming out of the community and the clinics will end up there before it can go further. Desmond had to go to a clinic before he ended up in the hospital, and then he went further. By the way, when I left Geneva myself, I had to undergo emergency surgery in 2017. And again, my story is quite emotional. I don't want to go through it. Anyway, so the district hospital plays two roles, if I can categorize them like that, and I'll elaborate. The first role, obviously, is clinical. That is well known by everybody. And I'm going to be very specific with the surgical services. The clinical role, obviously, is that it should be the first place where anything that's kind of complex should get to. The patient should be stabilized, if possible, at the district hospital. We know that the district hospital may not have the capacity to do all the complex things, but at least they should be able to stabilize your open tibial fracture, or is it a femoral fracture, properly. And whatever other surgical condition you may have. For example, if you're looking at cancer, we're having problems with cancer control. And one of the problems with cancer control is the late presentation of the patients. But it's not only late presentation. Sometimes patients do present to our health facilities with a swelling thing, which is very painful, and we keep giving them paracetamol because we don't have the capacity of anybody to actually do an X-ray and say, this looks like a tumor. We should try and do a biopsy so we get a tissue diagnosis, because without the tissue diagnosis, you cannot get anything else. And people get sent to this clinic, to that clinic, to that clinic, to that clinic. So the primary health care, the district hospital should be able to provide the needed screening, diagnostic, and stabilization and treatment services in surgical disease, because that's the closest we can get to the patients as possible. Now, it's not only doing something there, the district hospital also usually should have referral systems to the community, back, and obviously to go up. Desmond Tanko had to go on a private vehicle to the hospital. I had to do the same. I had to drive myself because I had acute abdomen. You can imagine you have these acute abdomen, sustained pain, and you have to drive through traffic in Lusaka. So the referral system also is a role that the district hospital should provide. Yes, some ambulances can come from, but most of the clinics usually don't have the ambulances. But the hospital could have an ambulance and go and pick patients up and bring them, and also to take the patients to higher levels, because not everything can be done there. So it has a referral role that it can play. And the surgical teams, who are specialized workers, quite trained, also are part of the leadership team. There's governance in health systems. Even in surgical services, we have to coordinate, we have to govern properly. So they also have a management role that they'll have to play for the district. The district surgeon sometimes also meets the district political leaders. And so they have a key role to play in governance and coordination and management of health systems within that district. Now, the second role for the district hospital, why we want it to be capacitated with surgical systems and strengthened so that it can support the primary health care, is the public health role. So far, surgeons or surgical services or surgeons or surgical staff in their totality are confined to the operating theater in the tertiary level hospital, in the four corners of the theater, and that's all they do. We don't want that anymore, because we have other roles that we feel we can play and we think that you can play. Like what? For example, the surgical teams at the district hospital can play a role in designing, prevention programs that can empower the community. For example, like I clearly said, they can have joint community engagements. How? In the district hospital, if we're present there, we have the data. We know who's drowning, like my friend here said. We know who's having road traffic accidents, which age group, which and the risks that they are having. That information, first of all, auditing of that information should not stay at the district hospital or be sent up to the ministry only. It should be useful for the community. That information can be used to engage the other leaders, the police, the political leadership, the religious leaders, so that the community understands its risks. Now, it's also the teams at the district hospital can also play a key role in communicating with the community to empower them with that kind of information. And also, they are a trusted source. If me as a surgeon come to a radio station to discuss issues of burns in the cold season in Zambia, all the members of the community will stand up and listen to me because I'm giving them firsthand, real-time information from their own facility, from what I'm seeing coming from their community. And I'm also trying to give them information on how they can prevent it. For example, in Zambia today, we're getting into the cold season. In this season, we all see a spike in the number of burns that we see. And it's usually the children that are affected. And we also know that our services are not so good such that the mortality rate of burns patients is almost 95%. The community needs to know that you should be careful with your children now. If you leave them unsupervised and they get burnt, they come to our facility, they are dying. Almost all of them are dying. So don't think that when they come to our facility, probably they'll survive. Of course, that's bad news, but it's better that I tell you so you prevent it rather than you think that, oh, even if they get burnt, they'll go to the hospital and they'll get saved. Okay? So they will be a trusted source of information. Sensitization in that regard obviously becomes an important thing. The surgical team can play a role in that. There is also information we also have other stakeholders in the community. We have NGOs, civil society organizations that are also focused on health. They need to be advocating and empowering and sensitizing the community with real facts, real information, real things. Most of the time, they will talk theoretically. But if we work with them and engage them and empower them, and also have strategies, there are those, for example, that are working on alcohol abuse in young teenagers. We have to give them the statistics on the road traffic accidents and the actual injuries that they get and the whole process of what you go through if you have care. That information is needed by the community, and it will be very, very useful. We also have to encourage the community on their health-seeking behavior. Most people, most health systems always report that patients come late. Why do they come late? There are many reasons, obviously, why they come late. But we can encourage them to tell them what is surgical disease. If you have something like this, okay, I'll speed up. If you have something like this, it's a surgical condition. So we can encourage and tell them what is a surgical condition and where you can get treatment within their locality. We also have a role to bust myths, dispel rumors. There's all that going on in the community. For example, cleft lip and palate. Most people think that when a child is born with cleft lip and palate, either the parents committed some crime or some abomination, or it's witchcraft. And you've heard that there's a resolution about fortification. People are so averse to vaccines now and anything else that's coming from the health system. We have a role to show them that either you eat the fortified things or look at what could possibly come out when you have a child. So as a team, we have all those responsibilities to bust myths. And finally, maybe it's also, we have to help to consult, to help to engage the community so we know their priorities. We are trying to build the health system. We're saying, let's bring the surgical services down to the district hospital, but that's the supply side. We also have to try and engage the community to know what do they think about surgical services? What do they know about it? What are their fears? Is it their priority? How do they want it delivered? That information is important because so far in the global surgery community, we have been just the governments, the intergovernmental platforms, and the other non-state actors, but we haven't really brought the community in. So that aspect is also very important, and it's an entry point because then we'll be working on something that we totally agree to. And then the district obviously should try exchange of information from the community to the district and back to the community, and then from the district hospital up in the health system and then back. So that the plans that are coming from the province or the national level are actually based on information that is factual, that's coming from the community. That's what the community has prioritized. I can say more, and obviously there's a lot more you can say.
I know. I know you well enough to know you can say much more. Ambassador Chegab, Emmanuel touched on politicians or referred to the role of politicians a few times. But what I want to ask you, if we talk about horizontal systems, when we as surgeons or anesthetists, if we want to speak to government or politicians, there's this pyramid of power we have to enter. And if you're in Terry's position or Emmanuel, who was a health diplomat, we know they know how to get to the top quicker, but most of us don't. So how do we flatten the political hierarchy from a pyramidal system to a horizontal system that we get quicker access, easier access to discuss problems around universal healthcare, primary healthcare, to achieve that goal of universal access to surgery for all? Just your thoughts around that, please.
Thank you so much. First of all, for the invitation. It's really a privilege. As you said, I'm an outsider, and I find it very interesting to sit next to distinguished surgeons and anesthesiologists and talk about surgery. But I see my role as advocate, and particularly in the context of Ethiopia. So let me respond by saying that the solution lies into how much governments are willing to prioritize the primary health care. In the case of Ethiopia, the healthcare delivery is organized in 3 tiers. At the bottom rank, we have the primary level healthcare, whereby we have health posts, health centers, primary hospitals, and we also have tens of thousands of extension health workers who are dealing with patients on day-to-day basis. And now the focus is globally in Ethiopia is now moving towards primary healthcare, as it is more accessible to communities and addresses more than 80% of the people's common health needs. Now you ask about the flattening of the hierarchy. In the case of Ethiopia, the Ministry of Health has tried to restructure itself with the aim of eliminating the middle staff and for easier decision making. In our case, we have the health system, is the governance follows arrangements of the national level, whereby you have at the apex the Ministry of Health, the national level, regional health bureaus, at the zonal or what we call Wareda, county level, health officers, and then there are Kabales or lower level officers that deal with communities. But the challenge is, because we follow the federal system and there's a need for decentralization of power, there are issues that come up with budget and administrative efficiency as new offices and hierarchies emerge. So there is no easy answer, but what happens is it is always context specific in different countries, in different systems. But the bottom line is, in Ethiopia, the government is working towards increasing access closer to communities by providing improved packages and services. One example could be saving lives through safe surgery initiative and having operation rooms in health centers at the lower rank for attending delivering mothers. In our case, health centers usually serve as sites of referral to hospitals and do not provide operation services. So that's the bottom line. And we need also bottom-up approach, which is vital because it generates evidence and provides country-specific effectiveness and cost-effectiveness analysis to better inform decisions in power and hierarchy. So this is basically what I wanted to say. Thank you.
Thank you very much. I have some personal experience of that, that sort of moving surgical services out to the district. In 2009, I was asked to go and teach critical care to health officers in Awasa. And I thought they'd probably traveled quite far to get here for the course, 200 kilometers, 300 kilometers. So I asked them, 750, 800 kilometers. The furthest was 1,300 kilometers out of the Eritrean mountains. So I said, how long did it take you? He said, 4 days and 3 nights on a bus. I said, so are you, I'm sure while you're here, you're going to stay for a week or two to learn a bit. He says, no, I've just come to do your course. Then I'm going back because there's nobody else to look after my patients. And if ever there was humbling experience, it was that. And then 18 months later, we went back to teach the second batch and then to do training trainers. So I never needed to go back again. But then the same person came out. He heard we were there again. And he traveled just to come and see us, just to come and have lunch with us. And I said, how's it going? He says, well, so far I've done 70 C-sections for obstructed labor, and he had no mortality, and he did the spinals himself. And that's what it's about, you know. So, Tore, you the rest of the questions, I'm hoping we're going to have a bit lighter as we look forward to implementation, to planning things. I hope the hard graft is behind us. So, Tore, when I listened to your TED talk, because of 2013, simply because I couldn't find anything else about you, you said about how that innovation is only innovation if it has impact. And to get from an original thought to impact, you need collaboration. And that stuck with me. So how does the Leerdale Foundation work as an impact partner that the voices of clinical workers in emergency, pre-hospital, emergency, surgical anesthesia care can be heard and work in the processes of building this network, grassroots network in primary health care?
Well, thank you. First, a few comments on innovation. I think that is a very much misused word. Everybody's talking about it. And most people may relate it to breakthrough science or to new technology. But unless that is put in systematic implementation as coming to impact, no innovation has happened. So in my book, as in 2013, innovation is all about impact. And impact really requires collaboration. I recognize some people in the room here who have participated at some Utstein meetings. The Leerdale Foundation has had the privilege of supporting. And one of the outcomes of one of these meetings have been the establishment of the Utstein formula for survival, which is offering that the impact or the chances of survival may be expressed as a product of 3 factors. the quality of the science multiplied by the quality of the education to really teach people to apply that science. And then most of all, and most important, multiplied by the quality of the implementation. And I think there is increasing evidence that the biggest opportunity for more impact, for more innovation, is better implementation of knowledge we already have. And that requires really collaboration. I'm just returning from a conference in Cape Town called Aligned MNH. And the slogan for the conference was align strategies, accelerate implementation, and save more lives together. And the Lala Foundation had the privilege of presenting a thematic session on with the title From Donorship to Ownership. And very many potential innovations do not really come to fruition because there is some difficulty in going from the pilot to the early innovation to scale, to the major innovation to scale, and to really be embedded in Ministry Health-led healthcare programs. And the only way that can happen is to prove that this is better sort of, or more benefit from the limited healthcare budgets. So it requires a local ownership, and it requires a really solid evidence that this is the best bang for the buck, so to say. And there is a chain of events there, really going from a development or a science breakthrough to successful mainstream implementation. There's a lot of research showing that that may take, even in high-income countries, 15 or more years. And with further confounding factors in low-income countries, it may take even longer. And unfortunately, in most cases, never happens because something is happening on the way, and it needs to transition to local ownership. And that requires, in the context of healthcare, of course, both solid evidence. It requires buy-in and leadership from professional associations. Often there will be NGOs or donors in the early phases, but it needs to get implemented with thorough local ownership. And we've been privileged to work with the Global Financing Facility, which is a subdivision of the World Bank, for some innovations also in financing mechanisms for scaling up some of the promising developments. So, well, that was a long answer, and I don't know if it made sense, but the essence to repeat is that impact is all about, or innovation is all about impact, and impact requires thorough collaboration and local ownership.
Thank you very much. Okay, I'm sure everybody's getting thirsty. So for the next set of questions, there's one each. I'm going to limit them to 2 minutes, our panelists to 2 minutes. You know, if the WHO allows country statements 3 minutes, I think we can allow 2 minutes. So Desmond, you may start again. Can you just tell us about the grassroots advocacy that Operation Smile is doing, you know, for surgery and anesthesia or global surgery into primary health care, and specifically in West Africa, just briefly.
Sure. I want to clarify a point I made earlier you know, I don't want it to seem as though I don't think resolutions are important. I think they're crucially important. The point I'm emphasizing is that they're only important in as long as they reach their final goal, which is the patient. A question was asked yesterday as to how WHO is able to hold the countries responsible for the implementation of resolutions. And I agreed with the panelists yesterday who said WHO cannot do that. Right? The only people who can do that are the people who are sending the delegations to the WHO And those are the people that vote for these politicians. These are the people that pay their salaries. These are the people that elect them. In the case of global surgery, those people are the surgeons, the nurses, the anesthetists in those district hospitals that Emmanuel talked about, who are really struggling to provide surgical anesthesia care with very, very little in the most challenging conversations. These are the patients who are really struggling. And so their voices are the ones that have to be elevated. And unfortunately, I don't think we've done enough of that in the global surgery community. We've had great advocacy at the global level in places like this. We've had them in Washington, DC, but that's not happening on the ground. How do we make global surgery a local problem? Because unless we make it a local problem, it's not really a global problem. The resolutions are not going to be implemented. So briefly, from the Operation Smile perspective, what we're doing is identifying leaders within the community, surgeons, anesthetists, who are already passionate about advocating for surgical anesthesia care and providing them with the skills for how to effectively advocate to their leaders. This includes things like how to pitch to your leader, how to write opinion pieces. If you have an opportunity to be on TV, to be on radio, how do you do that effectively to draw their attentions to this? This is very important. We also have to support the professional societies so that they can again hold the ministers of health responsible for the resolutions that they sign in faraway places like this. In addition to that, we provide mentorship to them, guidance throughout the year, and finally, capstone advocacy projects, which enables them to truly implement a project throughout the year. My two things. My first message is to the professional societies in the countries around the world. How do we organize ourselves? How do you organize yourselves locally to elevate your voices, elevate the voices of those at the primary healthcare level, those physicians and patients? This cannot be done for you. This cannot be done for us. You have to do it ourselves. And the second message is to groups like G4 Alliance, WFSA, global entities. Please support these local entities at the grassroots so that they can elevate their voices. I really believe that this is what is missing in global surgery. We have to make global surgery a local problem. Until we achieve that, the implementation of the resolution is not going to happen. Thank you.
Thank you, Desmond. Wisława, do you want to add something to that from Peru specifically or South America in general? I specifically want to ask you about the surgical and anesthesia care for at grassroots level for the indigenous peoples who have very little or limited access to surgical and anesthesia services. I know it's a politically loaded question, but just shortly, your ideas, please.
Difficult question, but currently, grassroots advocacy of global surgery is lacking in my country, first of all. And Peru have a diverse geography, the range from the Pacific coast to the Andes mountain, as well as the Amazon jungle. This complex geography makes accessibility to healthcare sometimes extremely difficult and preclude a proper and well-timed management of patients, even under the most optimal healthcare conditions. And it is difficult for patients and parents to come together in an organized manner. The patient who lives in borders they don't have a good assistance for the primary health care. No? And in Peru, the name is el primer nivel de atención. When we think about the primary health care, we have to forget all the structure of the healthcare system. In Peru, we have primer nivel de atención, segundo nivel de atención, y tercer nivel de atención. But this is different to primary healthcare. And the natives and borders for them, they are very difficult to access to the primer nivel de atención. So we have to work a lot to provide this. This is first. And the second part is what do we do? Well, we are working together to trying to provide these services. Working together, the parents and patients try to obtain some attention, especially in special topics like scoliosis, congenital scoliosis, or rare orphan diseases, no, or different special pathologies. There are groups, but there are not formal groups, no? But they are in the coast, but in the mountains and in the jungle, it's very difficult for them to work together. And we try to work in this. And with Operation Smile, currently working with the Minister of Health through the framework agreement to provide comprehensive cleft care to patients in need and training program for medical profession in this field. No, this is a recognized and important NGO for Peru. But at the moment, we are working with the Policy and Advocacy Department of Operation Smile to help strengthen our healthcare system and increase surgical capacity through the donation of an operating room to help us manage the backlog of surgery that result from the COVID-19 pandemic. But grassroots advocacy work with them is certainly in the future. In this moment, we don't have.
Thank you very much. I've been given a sign to move on. So, Naima, you've trained over 300 anesthesia providers in safer obstetric anesthesia, making a difference to maternal and neonatal mortality. Now, I find that unbelievable. I mean, after theaterist and going to ICU, I'm tired after working with 3 anesthetists on a day. So I don't know how you train 300. So if you just tell us, what was the how do you do that at grassroots level, and what was the impact of that, please?
Thank you very much. I mean, this is my patient, and I'm given only 2 minutes. It's not fair, but I'll try to shorten it up. So it started all back in 2015 in Tanzania, and I will like to take this opportunity, although they are not here, Jolene and May, they have worked so hard to make this happen in Tanzania. Please, big applause for them. And they pitched the idea to WFSA, and the WFSA were kind enough to trust in us and give us the opportunity to train the trainees. So the trainees are some trained for 1-year course in anesthesia, and some of them, they're on job training. Imagine somebody on job training going to give anesthesia for surgery. The course has brought a lot of impact in their management. So after the idea was pitched, the funds came, and we got the opportunity to train them. But that was not possible if you don't talk to the big boss, that is the district medical officer, the regional medical officer. So you have to have like a political meeting with them and telling them this is very important for them to attend, and it will bring a lot of change in their practice. Hell, that was a work to do, but we managed. And through them, it became like necessary for the participants or the delegates to attend the meeting or to do the course. And after that, that was not enough, because once you have done, they go back, and what do they do there? It's important to follow. The Safe Obstetric has given voice to the anesthesia provider in the district hospital, because when they used to go back before the courses or before the introduction of the course, they used to go back to the ward and do the routine nurse work. and not recognized as nurse anesthetic because the theaters were not functioning, or there are only 1 or 2 surgeries done in the whole day. So because of the limit of the resources, they were forced to do that. So we kind of like, through pitching the idea and telling them what the course gives them, not only the management in theater, but also management of the woman who has a critical condition such as PPH and eclampsia, they also have role there. So that then gave them a room of staying in the labor room, and when the condition become worse, to escort them to the theater. So this is what has done to the grassroots. But also by doing that, they have a direct contact to the woman and to the child. As per yesterday's data in Tanga, we have no maternal complication due to anesthesia. There were some district hospital which used to do the general, what we call DKA anesthesia without intubating, if you know what I mean, dexamethasone and the diazepam and the ketamine anesthesia, which is not a standard way of giving anesthesia. And now all the district hospitals are giving spinal anesthesia, which is the safer way of carrying out the C-sections. So this is what the course has implemented a lot. WFSA, every person in Tanga today is thanking you people because they're getting a safer access. And I'll come back to your Desmonds. This is what we have done. This is what the society has done for us as a local. And I'm the live example sitting in front of you saying that this is what has been made possible for people to get a safer surgery access to the district level. Thank you very much. Minutes was that? 2 minutes? Yeah.
So can I just, Tori, I don't know if you want to add something around that, about the work Leerdal is doing in Haydam, in Manyara district, and also in Ethiopia, about this, care for the obstetric patient and the neonate, please.
Yeah, I try to be short, but it's really our privilege to support what's going on locally. There is we have been working with resuscitation and trauma for many years and training programs when it dawned on us that where we could really have impact was to help babies breathe at birth. And a program was designed in a very innovative way, I think, and an alliance with first 4 or 5 partners, USAID, Save the Children, UNICEF, and NIH. And then this spread, and it became 10 different programs dealing with 75–80% of the causes of death for both the mothers and the baby at birth. And this has been thoroughly evaluated and informed the development of some innovative devices that are replacing some 150-year-old technology with PINAR stethoscopes and with regular stethoscopes for fetal and newborn heart rate monitoring. By now, there are 15 PhD studies that have been defended. There is another 10 underway. 7 of those are by Tanzanian researchers. More than 100 peer-reviewed papers have been presented. And this led to a program that was presented at this conference in Cape Town 2 weeks ago, with the aim of reducing by 50% early mortality of newborn, 25% stillborn, and 10% maternal mortality. And with the support of the Global Financing Facility, this is now about to scale up in 140 district hospitals, fully covering 5 of the regions. And it's really strongly owned by the Ministry of Health. So I think this is an example of innovation by taking something to mainstream implementation and also truncating the time it takes, and really going from donorship to ownership. So it's been really a privilege to be part of that process. But it is not us, it's first and foremost locally owned.
Thank you very much. I'm sorry to limit your time because that's so interesting, but I get to the last few questions. Terry, how do you see the WHO member states, civil society, in terms of the societies of surgery, anesthesia, emergency care, critical care, nurses? How can we all work better together towards universal access for surgical care through the goal, WHO goal of primary health care, please?
So if I've understood this right, Fatis, you want me to tell you how the entire world can do this well in less than 2 minutes?
Well,
look, I think there are, I do like the idea of flattening the hierarchy and connecting people. There are different functions, however, they're very complementary and they empower each other. So I'll try to bounce through this very quickly, picking up on many things that were said today, but you know, communities, you want them empowered. That is the PHC approach, empowered communities and individuals. What we mean by that ranges dramatically. So from the WHO point of view, it might be the CFAR program, the community first aid responders. From what Tore talked about and his life's work, largely, he does a million things now, but really at the center of it has been empowering bystanders, individuals at home to save lives. Desmond brought this up as well, the role that bystanders played as the first part of his care continuum. We want health education of the kind that Emmanuel spoke of. And so many people, providers at hospital level, at community level can be, I mean, at clinic level can be deliverers of health education for communities. We want people empowered in self-care. And then some concrete examples. We just published through the road safety team this book on how NGOs, local community NGOs, can advocate for emergency care. So we want communities empowered in all those ways to take care of themselves, to take care of others, but also to speak their voice about where they want their healthcare delivered and how, and to empowered to speak to their governments about that. From the point of view of WHO, how WHO can come together is, you know, we work for him. And so countries express their orders. We're a member state organization. They express their needs and desires to us in many ways. One of the most powerful is through resolutions, but it's also through a series of country requests. And it ranges, it's a little bit crazy. So from the PHC point of view, the most powerful mechanism is PHC for UHC. What we mean by that is countries have to delineate a set of services that they are going to prioritize to have universally available. That's what the U is. And that's not everything. Nobody can get everything to everyone. So the idea of prioritization is what UHC is. So one thing that we do is from the highest level, we have a tool now to help countries build these packages. For the first time ever, the surgical services that are usually left out of those are listed in every single health area. To Desmond's points, to Naima's points, you go down, you get in every single health area, whether it's non-communicable diseases, communicable diseases, for children, for adults, you get the surgical and anesthesia services that are needed. You also get the devices, medications, and equipment needed to deliver those. So the goal is, to Emmanuel's point, if you want your district hospital to play a very strategic linchpin role in your health system, you need to put it in your UHC package, and you need to choose services and assign them to the district hospital and know what are the health workers and material resources that you need to deliver it. So that's a WHO job, to build a tool like this that anyone who wants can use it. The professional societies have this incredibly powerful role, right? So there's the kind of global engagement that you do with WHO, where we're building technical products together right now with G4. The operative case encounter registry is a good example. But you have a cascade where you directly support people who are trying to deliver care in these countries, and also governments. And so that doesn't go through WHO. So we build tools together, but this professional cascade is incredible. You need to tap that powerful sense of professional identity, that sense that you found a professional tribe. That is very, very powerful. On the other hand, I would say make friends. That is the other very powerful thing that you can do. Desmond, what you spoke of is your access to surgical care. Some people would call that emergency care. What you spoke of as your perioperative care and your recovery, some people would call that critical care. What you spoke of as what Dr. Vislava spoke of as the kind of early recognition, the overcoming these social determinants of health and recognizing elements such as superstition in terms of a condition like cleft palate and cleft lip. Some people would call that primary care and family medicine, would see that at the center of that. You know, where I have to go tonight from here is the World Association of Family Physicians, an incredibly powerful group who are your allies. So I would say that, make friends. This idea of primary care at the center with all of these things connected to primary care by transportation, communication, and fundamentally supportive supervision and the management functions that Emmanuel mentioned, some people would call that the ecosystem or the eco-continuum. So we need to pull these things together. In terms of partners, Tori was quite modest, and we'll talk about this later in the week, but thanks to the American Heart Association and Lerdal, we're going to be able to do our function of convening as WHO and bring together through the Acute Care Action Network, something that will hopefully bring us all together with the goal specifically of supporting action, not only knowledge transfer. And then finally, I guess, what I would say is, you know, the governments, the ambassador was also incredibly modest. He put it in a subclause of a subclause, and I don't know if you heard it, but the governments execute these kinds of things, especially the system. When you listen to Desmond telling his story, it is inherently governmental. Some of these things live in the Ministry of Transportation, in the Ministry of the Interior, in different governments. But what Ethiopia did, this Wareda transformation, was extraordinary. So this is how these things get operationalized, and this is how we are all inspired. So he really mentioned that very quickly, but it's a story you should all know about what happened with the Wareda transformation. And then the last thing I'll say, Fanis, is thank you. It was extraordinary the way that you brought us together and how you pulled this off. And it took an enormous amount of focus and energy. And I know this was very, very close to your heart. And it was a little bit like a symphony, what you conducted us through this evening.
So, we're over our time, but I just want to give Emmanuel, you've heard all this. Is there anything else you want to add about what the surgical workforce want to see in implementing resolutions? Do you want to add anything that's not been said?
Well, it's just to echo things that we've said over time, obviously, that the governments and the ministries of health should take responsibility, leadership and ownership of if anything is going to happen on the ground, because it's actually what happens on the ground that matters. The magic is on the ground, not up here or anywhere else. Again, it doesn't matter what documents we create, whether they're national, regional, or country documents, unless we actually implement and do something about translate them into action that touches the patient. It's basically useless and a waste of time. For us as a surgical teams, we would like to see the surgical services that are so much needed, that are so essential, that are so impactful, present as close to the people as possible. We want to see them at the district. We are willing to work in the district hospital. The government should facilitate and open up the establishment, because they one time say they want services at the district hospital. On the other side, they don't want to open up the establishment, because you have to create the position for the surgeon, for the anesthetist, for the perioperative nurse, for it to be placed there. Because the skilled surgeon is not going to go and work in a junior capacity in the district hospital. So you have to create the mechanisms to facilitate that. They should work with partners to ensure that we have the right equipment. We have the technology now for information management, for stable power generation, and maintenance of equipment, so that we can have the right tools that we need. Until and unless we do that, it's going to be a struggle. Investing in surgical systems is the best way of strengthening the health system. It's the best way to actually get better health outcomes. We've done well, but we've plateaued in some things like maternal mortality. We need to bring it further down. In trauma, we don't even have done anything. And then, of course, surgical disease is physically debilitating. In our environment, in the low middle income countries, it means poverty and wealth. It means life and death. So if we really want to have that workforce that is healthy and can drive our economies, we must reduce the disability that is resulting unnecessarily from surgical disease. And we can save lives. Thank you.
Thank you very much for that last point. I'm going to leave the last word with Ambassador TEWG. When I listen to resolutions and I think about it, we often, my impression is that these are often driven or carried by low-income countries. They do the hard work, like SADC, like the Pacific Islands. How do you envisage Ethiopia with the African Union, who are at the forefront of this new resolution, and with support by EU? How do you see, can the governments, can Ethiopia through AU and EU provide the leadership and the political will, all these countries, to get us to the point where all or almost all nation states will support the implementation of resolutions that support surgical care in all communities? Do you see a path to that? You don't have to go into the detailed politics, but can you see a path, please?
Thank you so much for the question. I do not know if I have specific answers, but what I can say that is there is a political will in the part of Ethiopia to play a lead role amongst these developing countries and African Union member states. As you know, we have this current proposal on integrated emergency, critical and operative care. And we believe that it provides an opportunity to provide greater attention and support to surgery, obstetrics, trauma, and anesthetic care. And in our continent, where I come from, we have the African Union, where the AU plays a great coordinating role by mobilizing member states to translate the resolution into regional action plans and support for country implementation. We already have, as AU, an Africa Health Strategy for 2016 to 2030. And this resolution can be seen in this area as well. And we see the AU has a communication, advocacy, and coordination role. Of course, we also, when we speak about coordination, there are also regional platforms. We need these regional platforms in light of the challenges that we have for medical supplies and equipment when we talk about quality care for surgery, obstetrics, trauma, and anesthesia. So we have now countries are benefiting from pooled regional procurement arrangements, and there is the African Medicines Agency that is established to allow this. So further arrangements could be made to building this through Africa CDC and African Medicines Agency. One final point I would like to point out is the importance of financing. Governments need to, uphold to Abuja Declaration of 2001, where they committed 15% of budgets to health, but this progress has not been achieved, and it remains vital to strengthening our primary healthcare. And last but not least, political will, as my colleague just said, ownership, and all this has to happen from the ground up. So this is what I would like to say at this point.
Thank you very much. There was an urgent question from the audience. I'm sure there are many other burning questions from the audience. I wanted to ask Tori still about how Leerdal will contribute to ACAN, but that's being discussed on Wednesday. I think we need to stop it there. For you who live in Europe, this is warm. For us who come from the south, this is just mild. So, but I know it's warm, people get thirsty, people get tired. So thank you very much to the audience, but thank you very much to our excellent panelists. I think I could have gone on another hour or two, but thank you all for answering, for contributing, and for the flow you created. Thank you very much.